Hi everyone. I'm just I hope it went. I'm not sure the okay. I'm really having an issue with Instagram, but I think it went through. You're live. Yes. Okay. Hi. I'm gonna get more and more familiar with all those lives. And so I'm really excited to be here again. Last time we did what is rheumatoid arthritis. Actually, today we're going to do how do we diagnose rheumatoid arthritis. And there was some discussion in some comments in the YouTube, and it was really wonderful to see the beginning of some discussion. So those are not medical advice. As usual, you have to go and see your rheumatologist, but I'm really, really happy to talk more about how like all of the rheumatologic topics. Okay, so without further ado, how do we diagnose rheumatoid arthritis? So you can actually have rheumatoid arthritis that's both seropositive as well as seronegative. What I mean by that is that you absolutely could have rheumatoid arthritis even though the blood work doesn't show that you have the markers, as I hear it sometimes with patients. It's a clinical diagnosis first, and then we confirm it with blood work. We can confirm it also with x-rays. And so remember last time I was saying, if you have a rheumatoid arthritis, like some of the pain that you're going to have is pain that's worse in the morning, that's associated with more than 30 minutes of morning stiffness. So you're stiff in the morning, and that improves with exercise and with use. And so once we see this, that tells us as a rheumatologist, oh, something is going on. That may be rheumatoid arthritis. So then there's like a couple of other signs. Number one, so you have inflammatory arthritis. Number two, you're going to have involvement of both symmetric, basically, of both your hands or both your feet, both your knees, both your ankle, both your wrist. The vast majority of time in rheumatoid arthritis, you're going to have involvement of your hands as well as your wrist, and you may have some swelling related to that. Second thing is to realize that, well, you not necessarily know, we don't really know why rheumatoid arthritis does not affect the DIP, which are those joints. And so those joints are usually affected in osteoarthritis, which is this wear and tear. And second, it's going to be affected sometimes in psoriatic arthritis. So when we see this, we are like, well, is this really rheumatoid arthritis? And it really depends on how you present. Okay. So the number one thing is to say, okay, well, rheumatoid arthritis is a diagnosis that's clinical. And so we are looking clinically how you're presenting. So that's number one. Number two is when you have this inflammatory arthritis, we're going to do an exam, and we're going to look at if you have any sort of synovitis, which is inflammation of the synovium. And the synovium is what keeps together the joint. I'm showing this one here, for example, one here, but there's one on every joint. That's why sometimes you have swelling of your like your knees, for example, or your ankle. If you hurt yourself, there's going to be inflammation, and then, or maybe blood, or anything, and so then it's going to grow, and that is usually inside the synovium. That's why it's localized. Okay, so the rheumatologist is going to look for synovitis. The physician is going to look for synovitis, so inflammation of the synovium, which is basically showing us that your joints are warm, they are tender, they are swollen, right? We're looking for that. We only need one joint swollen, like synovitis. And if you have inflammatory arthritis and you have at least one joint that's swollen, then we can actually say that you probably have rheumatoid arthritis if it's symmetric and fits all of this. And then there's a couple of other things that we can do. So in addition to the exam, sometimes we're not completely sure. We can take an ultrasound and look at it. I would say that for a diagnosis of rheumatoid arthritis, you probably just want to do clinically. So normally your physician should be looking at your joint. But if there's doubt, sometimes I like to put my ultrasound machine. Honestly, I also like to look at the ultrasound to also show other people, like my patients, if it's doing well or not. So that's like this. Then we can do x-rays. X-rays are gonna, like, we do x-rays to see if there is any sort of erosion in your joint. And so that is going to tell us that you actually have a pretty severe and pretty advanced rheumatoid arthritis. So either it's aggressive or it's pretty advanced, because we are trying to prevent erosion. That's really what we're trying to do with our medications. And so we're gonna look and see with x-rays if you have any sort of erosion. And we like to do hands and feet, no matter if you have pain in your hands and feet. What I mean by that is that you can actually make a diagnosis of rheumatoid arthritis because of erosion on the fifth MTP, which is, imagine that this is my foot. This would be the fifth MTP. So, right, like where the peaking toe is, and you go all the way to the base, and we can sometimes see an erosion here. And it's actually an area that rheumatoid arthritis loves. And so we always do the x-rays of the feet because we can actually find that. I cannot count the number of times I made a diagnosis of RA based only on this x-ray, in addition to inflammatory arthritis, of course. But we see that erosion, and then that's telling us so much. And of course, you want to check erosions on your hands. And it's also a baseline. As you treat, you want to make sure that our patients are not eroding their joint. But how do you know it if you don't have a baseline? And then we have the blood work. And so in general, we're going to look if you have any sort of inflammatory markers. So CRP, ESR, those are inflammatory markers, and they can be high, but they can also be normal. And that doesn't mean that you don't have rheumatoid arthritis. And then the second is we're going to check CCP and rheumatoid factor. CCP is much more specific than rheumatoid factor. What it means by that is that if you have CCP that's positive, it is most likely that you do have rheumatoid arthritis, or at least that you have a risk for rheumatoid arthritis. Whereas rheumatoid factor can be positive for many and plenty of reasons, some of which could just be like you have had an infection, especially like chronic infections such as hepatitis C, or you have some lung disease, you can have a positive rheumatoid factor, or really we don't find any reason and you still have a positive rheumatoid factor. So that is, that's important if you have, in the right clinical setting, if you have an inflammatory arthritis that's symmetric, that affects what we call the PIP, the MCP, the rest, but not the DIP, that's symmetric. That maybe you have the feet, maybe you have an erosion, and then you have a positive rheumatoid factor, then we're going to say, okay, seropositive rheumatoid arthritis. But in general, CCP is more specific for this. So in general, it's a clinical diagnosis that's confirmed with x-rays. If you have erosion, that's confirmed. Or if you have, and then we're looking if you have CCP and rheumatoid factor to see if you have what we call a seropositive rheumatoid arthritis. Seropositive rheumatoid arthritis have a tendency to be more severe. And so we are going to treat them a little bit more aggressively. We're going to go faster to a biologic if we need to. And also, like, lifestyle medicine usually are not enough to take care of the seropositive rheumatoid arthritis. You can still have a rheumatoid arthritis and not have erosion and not have any sort of markers like CCP and rheumatoid factor, or even elevated ESR, CRP. You may have all of those normal, right? Like the blood work may be completely normal, and you may still have a rheumatoid arthritis because it's clinically diagnosed. In general, we do say that you need to have at least one swollen joint. And if you have what we call seronegative rheumatoid arthritis, so seronegative, non-erosive rheumatoid arthritis, in general, for those patients, I would say that personally, I follow them, and I'm always very open-minded about the fact that maybe something else is going to come. So maybe it's lupus, so we want to make sure that it is not lupus by checking an ANA. Maybe it's a psoriatic arthritis, and we still don't have the psoriasis now. And so you want to just follow them with an open mind. So I think that is a good start for like explaining how we diagnose rheumatoid arthritis. It goes into a little bit of details depending on each patient, of course. Although those are not clinical, like how do you call that, medical advice, I'm happy to answer your questions, so don't hesitate. And then I will see you next week for how we treat rheumatoid arthritis. Have a wonderful day. Take care, everyone. Bye bye.